In this video, I'm going to discuss the clinical features of the disorders that are associated with the galactokinase, galactose 1-phosphate uridyltransferase, fructokinase, aldolase B, as well as pyruvate kinase and pyruvate dehydrogenase enzymes deficiency. So first, starting with the galactokinase and galactose 1-phosphate uridyltransferase, here is the pathway where it shows you that the galactose is being converted into the galactose 1-phosphate via the galactokinase enzyme. And then later on, galactose 1-phosphate will be converted into glucose 1-phosphate via uridyltransferase, and then glucose 1-phosphate can now enter the glycolysis or the gluconeogenesis pathway. Now, deficiency of any one of these enzymes will cause accumulation of the galactose and thus cause galactosemia. Now, because of the accumulation of galactose can be converted into the galactitol via the aldose reductase enzyme. And galactitol is the underlying cause of infantile cataract. So now let's go through the table. So with the deficiency of the galactokinase, there would be accumulation of the galactose, which via aldose reductase will be converted into galactitol and cause infantile cataract. With deficiency of the uridyltransferase, there is now accumulation of both the galactose as well as the galactose 1-phosphate. So again, elevation of the galactose via the same pathway will lead to the development of the infantile cataract. In addition, because of the accumulation of the galactose 1-phosphate precursor metabolites, now there would be other features like failure to thrive, mental retardation, hepatomegaly, as well as jaundice associated with the deficiency of the galactose 1-phosphate uridyltransferase. The next enzymes are the fructokinase and aldolase B, which are required for the conversion of fructose into the glyceraldehyde. So fructose will be converted to fructose 1-phosphate via the fructokinase enzyme. And then fructose 1-phosphate will be converted into glyceraldehyde via the aldolase B enzyme. Now, deficiency of these enzymes will cause fructosuria. However, with the fructokinase deficiency, it's only asymptomatic, and you will see the elevation of fructose in the blood or urine, but there are no symptoms associated with this disorder. And so therefore the name essential fructosuria is given to the fructokinase deficiency. On the other hand, patients with the aldose B deficiency will have much more severe symptoms, and thus the name fructose intolerance is given to conditions that have aldolase B deficiency. So with the aldolase B deficiency, what happens is that there would be accumulation of the fructose 1-phosphate. So phosphate will keep on being used for the production of fructose 1-phosphate. But since this product can no longer enter the glycolysis pathway and the phosphate pool is being depleted, therefore, there would be inhibition of the glycogenolysis as well as the gluconeogenesis pathway. So since we don't have any more phosphate left because of the accumulation of fructose 1-phosphate, the depletion of phosphate pool will lead to the inhibition of the glycogenolysis as well as the gluconeogenesis pathway. And so therefore, there would be low glucose that will cause hypoglycemia. Other features of this disorder include jaundice, cirrhosis, as well as vomiting. The next enzyme deficiency is the pyruvate kinase deficiency, and so pyruvate kinase is an important component of the anaerobic glycolysis for ATP production. Now you know that red blood cells lack any mitochondria, and thus the only way they can produce ATP is via anaerobic glycolysis. Now if you disrupt the pyruvate kinase, therefore you're disrupting the glycolysis pathway, and thus red blood cells can no longer produce ATP. So therefore, due to the decreased production of ATP by red blood cells, there would be hemolysis, as a consequence of which patients present with chronic anemia and jaundice with hyperbilirubinemia. So bilirubin will be elevated. And then if I ask you what type of hyperbilirubinemia is associated with pyruvate kinase deficiency, what would be your answer? Would it be unconjugated or conjugated? And the answer is unconjugated. So since now there is too much bilirubin, it will be saturating the conjugating capacity of the liver, and thus the unconjugated bilirubin will keep on accumulating, and that would lead to the development of the jaundice. And then finally, we have the pyruvate dehydrogenase deficiency. So pyruvate dehydrogenase is the enzyme that is required for the conversion of pyruvate into the acetyl-coenzyme A, which will now enter the TCA cycle. Now, before I go through the features of this disorder, I would like to provide a little background on pyruvate dehydrogenase complex. So pyruvate dehydrogenase complex is dependent on many different cofactors, including vitamin B1, B2, B3, B5, as well as lipoic acid. So therefore, conditions like, for instance, alcoholism that causes deficiency of the thiamine will interfere with the pyruvate dehydrogenase, and thus patients will have neurologic problem, as a consequence of which they could develop, for instance, Wernicke and Korsakoff syndrome. And then on the other hand, conditions like arsenic toxicity will interfere with the lipoic acid component of pyruvate dehydrogenase. And again, patients will present with the garlic breath, nausea and vomiting, as well as rice water stools. Now, one other point I would like to mention is that you may recall that cholera infection is another cause of rice water stools. So patients with arsenic toxicity also have rice water stool, but one main difference is that because of the increased leakage of the blood vessels, there would be a bloody rice water stool associated with the arsenic toxicity, versus the cholera, it will cause non-bloody rice water stool. So these were examples of acquired causes of the pyruvate dehydrogenase defect, like for instance from the arsenic toxicity or alcoholism. You should also note that this enzyme pyruvate dehydrogenase is being activated by exercise, which causes elevated NAD plus to NADH ratio, elevated ADP, and elevated calcium. Now, one last point I would like to mention about the pyruvate dehydrogenase complex is that the most common cases of pyruvate dehydrogenase deficiency is from X-linked mutations in the E1 alpha subunit. So X-linked mutations in E1 alpha subunit is the genetic cause of the pyruvate dehydrogenase deficiency. So with that background in mind, I would also like to remind you that the pyruvate can be converted into many different products. It can be converted via the pyruvate dehydrogenase, which we just discussed, into the acetyl coenzyme A, which will enter the citric acid cycle. So if now there is deficiency of these enzymes, then there would be shift of the pyruvate towards the other pathway. So now there would be elevated level of lactate as well as alanine production because of the deficiency of the pyruvate dehydrogenase. So now let's go back to the table. So pyruvate dehydrogenase deficiency will lead to fatal lactic acidosis, because now there is no more conversion of the pyruvate into acetyl coenzyme A, and instead pyruvate can be converted into the lactate. So therefore, patients can develop fatal lactic acidosis, and also due to the interference with the production of ATP, there could also be some other neurological defects, like for instance seizures and mental retardations. And so therefore, in order to decrease the production of lactic acid, treatments are directed at increasing the intake of ketogenic nutrients, which for instance have high fat contents or a high content of the lysine and leucine amino acids. And that concludes our discussion.